So thank you very much, Dr. Kumar. It's really an honor and a pleasure for us to participate to your prestigious meeting. So thank you very much for invitation and to the organizing committee. Let's introduce the staff who is working today. So we have Dr. Saya, who will perform the procedure, Dr. Taglieri, and then we have the nurse staff, Cristina and Luana, the technician Michele, and the anesthesiologist, who is Ferella Marta. So without any further ado, let's introduce the case. So Dr. Antonio Bruno will show you the case. Special greetings to Dr. Kodari.
Okay, can you hear me?
It's really great to see you again. Always in depth with you, with all the great things you have been teaching me in the old days. So very nice to meet you again.
Tulio, Eberhard is on the line as well. So Eberhard will be moderating as well.
Okay, all right, okay.
Hi,
so
everybody.
Let's introduce the case. Antonio, please show us the slide.
Hi, everybody. This is Antonio Bruno from Bologna Hospital. It's a pleasure for me to be here with you. This is the case of a 87-year-old lady, which is who is affected by hypertension and paroxysmal atrial fibrillation, and no other relevant comorbidities. She has a remarkable cardiological history until April 2022, when she was admitted to our institution for heart failure. During this admission was performed a cardiac ultrasound that shows a severe aortic regurgitation, a severely reduced ejection fraction of the left ventricle, and a moderate left ventricle dilation. During this admission, because of the age of the patient, we firstly tried to optimize the medical therapy. Despite this optimization, in July 2022, she was still symptomatic for exertional dyspnea, and then she was discussed in our team and then accepted for TAVR. This is the echo of our patient. She has a severe aortic regurgitation with a moderate left ventricle dilation and a moderate left ventricle ejection fraction reduction. This is the coronary angiography. The coronary are remarkable. There is just a moderate ostial LAD stenosis. This is the CT scan analysis. As you can see, the area of the virtual basal ring is 345 millimeters with a perimeter of 66 millimeters. The sinus valsalva are of intermediate dimensions, and the right coronary artery offset is normal, which is about 16 millimeters, but the left coronary artery offset is quite low, it's about 7 millimeters. As you can see in the left upper panel, in short axis, when we cut at the height of the left coronary ostia, the left coronary cusp is still visible, which means that it is quite high. And as you can see in the left lower panel, the virtual valve to coronary ostia distance is 3.8 millimeter when we put inside the annulus a nominal 23 millimeter Sapien 3 ultra valve. Finally, this has the HS. As you can see, the iliofemoral axis has no concern. There is no concern at all because the caliber are good. There is no tortuosity, no calcification, and not stenosis.
So let's summarize the case, and I will raise two issues that we will discuss in a moment. First, we have a patient with the pure aortic regurgitation, and so the question would be, would you do this case? We know that there are specific valve for aortic valve insufficiency, the Jena valve, but unfortunately, this valve is still not available in our institution. It will become available soon. So with a valve which is not designed for this kind of pathology, would you do that? If yes, which kind of valve would you use, and which kind of oversizing would you use? And then the other question is, would you protect this coronary artery? We know that it is really a borderline case. Probably it's not necessary, but this may be also an issue for discussion.
Thank you, sir. We are all
now,
excited. We are all excited to see this new indication. Just now, our surgeon was commenting AR and dilated aorta. You might leave to us, but you're already tackling that percutaneously. We're all excited and enthusiastic to see your presentation, your live case. And I think.
Absolutely. So before discussing
Tulio, can I ask a question?
Yeah, sure.
So, you know, there's AR, but she's 87 and it's tricuspid. On the CTs, the leaflets look a little thickened in some segments. I mean, there's always a spectrum. Is there any rigidity of the leaflets on echo that you see, or any thickening that you think would help provide some anchoring for the TAVR device?
Absolutely. We see some thickening, but not that much. So I think this is really a challenging cases for the anatomy, because the thickening is not that much. And as you could see, there is no calcium at all, no calcium at all. So there is really no anchoring if we think to a traditional implant. But then we can also show you other cases which probably are even more challenging than that, and according to which we have done some experience, and we are quite confident that we may be successful in doing this procedure. Again, before discussing a little bit deeper these issues, so let's move to Francesco. He has been doing some work, and he will show what he has been doing so far, and the principle of a minimalist approach that we have been using since the beginning in our center.
Thank you very much, Tulio. Good afternoon, everybody there. So what we did thus far is, our standard minimalist approach is to have as a secondary access, a radial access, and you can see that here we have a pigtail coming from the radial artery. Having some tortuosity, we are using a long sheath.
Can we see the fluoro screen?
Sure,
yes,
absolutely. Can we show the fluoro? So probably one question, we can ask one question. So how many people use and Sushi, what do you think? How many people use as a secondary access the radial artery? So this is something that we have been doing for the last 6 years. We never had issue. And also, if we have to fix some problem in the femoral artery because of ProGlide, we can do it through the radial artery. So is this something, I mean, how many people use this access as a secondary access?
I mean, I think it's an interesting thing, because when you look at the trials, about half of the vascular complications were on the non-large sheath side, because we always manage the large sheath side with either balloon tamponade and make sure we have 2 ProGlides and have good access. But oftentimes the worst access is the non-large sheath, and so radial would reduce that. We have not done that. We use Sentinel, so we use the right radial. I guess we could do bilateral radials, but we have not. I know in Cleveland Clinic uses the single, where they put both sheaths on the same side, and one a little bit lower than the other. I don't know. Eberhard, do you have any experience with single access, single side?
No, we are basically having the same approach as you do, Sushil.
So as you can see from the fluoro, we put a flexor 45 centimeter, which is a long sheath. It's very hydrophilic. So we put it there, and then whatever happens, radial plasma, whatever, I mean, you are really can manipulate the pigtail with no problem at all. So we are very confident with that. But please, Francesco, go home.
Okay. Second, most of the time, I personally use stimulation through the guide wire. In this case, I put a pacemaker, because there are 3 cases in which I put a temporary pacemaker, which are conditions like this, when we are, in aortic regurgitation setting, is a quite peculiar setting in which I prefer to stay absolutely, let's say, safe. I think that stimulating through the wire is safe. We have documentation of that. But in this case, as in other cases in which you can, predict some additional maneuver like coronary protection or things like that, these are the conditions in which most of the time I use a pacemaker. I know that Tulio preferred to use it in all the cases. But so I don't think this is the basic of a minimalistic approach. Third, I put in this case also another femoral access, as you can see, and this is because we decided to go with a coronary protection. We will protect only with the wire because we think that the likelihood of coronary occlusion is very low, but still, we need to oversize the valve. We saw that the space, the coronary takeoff is low, the space in the sinus is not that big. So, I mean, this is not, we know that the protection through only the wire is not the standard in cases in which the likelihood of occlusion of coronary compromise is high, but in this case, we think a low likelihood, so we will protect only with the wire. And then we did the projection. Can we show the projection, please? Okay, this one. These are the three cusps in the same plane. So this is our implantation plane.
Just the last one, please. Okay, this is one. So I think this is quite a good alignation of the cusp. So we like this procedure. And now Francesco is going to take the main axis. And as you can see, we use echo-guided puncture and echo-guided puncture in 100% of cases. So we just use a marker to get orientated about the height of the puncture, because you have to be aware that if you use just a pure echo-guided approach, you may run the risk to make a very high stick. So we always check with radioscopy that we are at the proper height. So again, another question for you. So how many people use such an echo-guided approach as compared to the classic approach? Dr. Grube or Sushil?
Yeah, no, we always use ultrasound guided. I mean, it started about 2-3 years ago, and I think it's just a safer approach. You can avoid calcium. You can see the bifurcation. You don't go too high that way. Go just above the bifurcation. I think it's the challenge, Tulio, for me is I'm older and I trained under fluoro. And it's hard to learn new skills, and it's always hard to admit that the fellows are better than you because that's all they've been doing, and so. But I've finally learned as well.
But I think it's important, Sushi, what you just said, because it was on my tongue, the tip of my tongue. With us, it's 50.
Important that the hold or about the technique. That is old. Is it important or the technique? The technique. I'm just joking.
I'm old. Yeah.
Okay.
Okay, you can see the site of the stick here, exactly, you see? So it's exactly where we wanted to stick. This is a double check with the fluoro, and you can see the needle. So that's the site in which we entered the artery. I hope you saw also the echo puncture.
So, and with this technique, especially if the patient has high creatinine levels, you can skip control of angio control of the femoral artery. So it's also a way to save some contrast. But what about you, Dr. Grube? Do you use echo or use angiography? Because
honestly speaking, many people would do on the angio-guided, but if you are comfortable with this technique, especially in patients who have high creatinine, I think as demonstrated, you can do it well. But obviously, we are more people are comfortable with cine. You can have a combination of both to give the best. The anterior puncture probably in the wall can be seen and bifurcation points can be cross-checked. But I would confess that most of the operators, 80% of them, are more not using echo guidance in India, but especially in such sort of scenarios where creatinine is high, you will be forced to use it. I think Dr. Grube sir, he heard or not, that's why I responded. We can proceed with the case. Thank you.
Absolutely. So Francesco now is doing some work with the ProGlide, and probably we can start the discussion about the indication for TAVI of this patient. knowing that, again, this valve was not created for aortic insufficiency. So my question to the panel are, would you do this procedure? Which is the valve that would you use in this case? Have you any preference for balloon expandable valve or self-expanding valve? And which kind of oversizing do you think it is necessary in a case like that? So if the panel can give some contribution to the discussion.
So I can start and let Eberhard weigh in. These are tough. I mean, I think there's no right answer. In general, when we've done primarily AR without calcium, as long as I can adequately oversize with a core valve, I've gone with self-expanding. You know, we've had cases where we've done a core valve and it ends up dropping low, and we've had to, hold it with a snare and put a sapien inside. But, Raj Makar has published a series of balloon expandables with AI, but the rate of a second valve is not trivial. So, here you had a perimeter of 66, I believe. So,
let's see it. Antonio, yeah. Antonio, can you show us again the annulus? So probably the slide before with the annulus and the oversizing and okay, this one. So the area is 345. You see. And again, this slide show you our choice. So we have experience. It's a preference. Of course, there are no data about that. There is no evidence. It's just experience that we have matured in these years, and we always prefer as a first step a balloon expandable valve. So here you see that you are in the range of a 23 millimeter valve. Of course, our plan was to put a Sapien 23 and put 2 cc more. That would bring the volume and the area to 453, and with oversizing of 31%. So our experience says us that we have to be between 20 and 30% as oversizing. With 2 cc more, we are not sure that we are going to give all the volume. While deploying, we will see how the valve behave and decide if give all the volume or just stop a little bit earlier. But we think that oversize of 30%, between 20 and 30%, may be safe and the right choice for this case. So what do you think?
Eberhard, any comments?
Oh yeah, I have a lot of comments, and I'm listening obviously very carefully. We've done it so many years now, and for me the most important thing is it is a very interesting case. We'll see what the result will be. I think something that's very important, and I would have done the same thing, is protect. The reason being that whatever valve you're using, balloon expandable or self-expanding, it is extremely hard to predict how the valve behaves in a given situation. You can have a ton of experiences, and I've seen this when I was in Los Angeles, with Raj Makar, and he has a lot of experience. We have a lot of experience. There's no way you can predict. The most important thing is if the valve, balloon expandable or self-expanding, moves up or down, then you might have a problem with the coronary. So I think the coronary protection is a very, very good choice, and I would very much support that. Obviously, the situation when we are doing the aortic regurgitation, we are very, very careful with that. We are using self-expanding valves simply because we have more tolerance. We can observe the valve better than a balloon expandable valve, which is obviously smaller. And a self-expanding valve, you can observe how the valve behaves. We always have a second valve ready, because if the valve moves, then you have to be very, very quick, either by holding it with a snare, and that takes time, or to get the second valve in order to secure the second valve, and we would secure the core valve or the evolute then with a balloon expandable valve.
Thank you very much for this.
Clearly no right answer, but I think this is good oversizing. But real quick, I know you'll probably tell us this when you're deploying. What you said you'll decide whether to do the volume based on how it feels. What are you looking for? Is it a waste in the valve, or is it pressure? How do you decide?
Absolutely. Great question. I think it's a question of experience. So of course you look the valve, how it expands and how it behaves, but you have also a feeling while you inflate the valve if you are pushing too much, or I mean you are in a situation in which you are pretty safe. Of course, this is not rocket science; it's experience that we have maturated in these years. But you know, so. We will see. So the other question is, would you protect the left coronary artery? So can we see the next slide, please? Antonio, can you show the next slide, please? Okay, so this, you see that the takeoff is quite low. It's 7.4, so it's, but sinus are intermediate. The other thing that is not really safe is that you still see the valve leaflet when when there is the takeoff of the coronary artery. But with the simulation, it seems there is enough space. But remember, this is a nominal 23. We are going to overinflate the 23. So our choice. So my opinion is that probably it won't be necessary to put a stent. But our choice was to put a coronary wire as a protection wire and then decide. What would you do in this case?
I agree. I agree with Eberhard what he said as well. I would definitely protect. In AR, it's a different beast. You don't know how these leaflets are going to behave. There's not calcium restricting. I think if you had a bicuspid with fusion of the right non, you definitely need to protect, and you're high risk. Here, I think you're probably okay, but you just don't know how these leaflets respond. There's not calcium holding them back, and you're overexpanding, so I would definitely protect.
So I agree 100%. So in general, if we are concerned seriously about coronary occlusion, we put the wire, we put the stent already in the position, on the final position of deployment. So when we are 100% sure that there will be an obstruction of a coronary artery. In this case, again, it would be probably okay. Well, we do not know for sure. So we think that it's safer just to protect it and then see. In borderline cases, we have been using IVUS. Do you have any experience in addressing the risk of coronary obstruction after you have deployed the valve using IVUS?
No, stanno vedendo una
don't. I haven't done that. You know, we've only IVUS when we've had to put stents to just see what the result was, but assessing risk with IVUS, I have not done.
Okay, so probably Francesco still now has already put the big sheath, and now is going to get into the ventricle. Probably we can see a case we did recently. Antonio, can you show the case? The other case, okay? So this was really a challenging case. So if we will have the slide in a minute. We don't see the slide. Can we see the slide? So next one. Next. Okay, before. Okay, this is the case. Okay, so you see that now.
No, non abbiamo toccato niente di sicuro. Hanno perso, è un problema loro.
So we don't see the slide. If we have the slide, I think it will be nice to show you this case.
I guess you're just going to have to show us live now.
So we will probably have the slide in a moment.
Non riesco ad andare avanti. ora ci riesco.
Okay, can you see the slide now?
Yes, we can see him.
Dobbiamo riuscire a vedere le slide, non le stiamo chiudendo noi, non la stiamo chiudendo noi.
Now just the text again.
So some technical problem. Okay. Okay.
I think we
Okay.
can proceed without slides directly. I think we can see you and hear you well.
Okay, so can you see the slide now?
No, it's just the text. Yeah.
Okay. So we will see if we can fix the issue and then...
Now we can see it.
Okay, so this was a case, of course, that had no surgical indication because he was a very, very sick patient. And on the other hand, he was on refractory heart failure. So we had to do something. And you can see in this case that we have really a large annulus. So the annulus was, if we can see the slide which show the measure of the annulus, was in the range of 70. So it was really, really a challenge case, but the patient was really in a desperate condition. And so we had approval from our ethical committee to do this case. So you see that it was 716. So, and again, very big aortic root and no calcium in the annulus, but just some tiny spot of calcium in the valve. Okay, so let's see the other one. Next slide. Okay, so as I said before, root is very big. The sinuses are in the range of 40. No issue with the coronary, which were high. So next slide. Okay, so what did we do? So we put a 29 millimeter plus 8 cc, So, and really we went all the way to deploy the valve. I don't know if you can see the slide now again.
No, just doing the same thing again.
Okay, so now you should see it.
No.
Okay, so probably, I mean, there are some technical problems we cannot solve. By the way, we put a 29 millimeter valve plus 8 cc, and actually the final result was very good with the success of the procedure and really no residual insufficiency. Then we did a CT scan just to sort out how much oversizing the valve took, and it was in the range of 25%. So that was our original plan. So, but let's get back to the case. So Francesco has already wired the left coronary artery. There is a wire in the LED. And now it will proceed, getting into the ventricle, and now we will ready to deploy the valve.
Okay, yes, in the meanwhile, as Tulio said, we put the sheath. It was quite smooth because the access was quite big. We put the wire in the LED as a protection, and now we cross the valve. And then I think we are ready to deploy. We already checked the pacemaker. We will double check just before. Okay, you can see no major issues in crossing the valve, of course.
So probably another point we could discuss in the meantime. So this patient is on Dextor, so the anesthesiologist is without, but the reason for doing that is only that this is a live case. But
it's aortic regurgitation case also.
Yeah, also, yes, and also
kind of backup.
Probably, yeah. Also, the indication is peculiar, but in the majority of cases we do just local anesthesia, and so Francesco has collected the data about the percentage of patients that we have done TAVI just with local anesthesia. Francesco, can you give us some numbers?
Yes, we start as a routine approach. with local anesthesia only, so PCI-like approach, only sometimes minimum sedation of the patient decided up front, but really PCI-like. We upfront plan a general anesthesia procedure. Let's say in last year it was in 4 patients out of 300, but this was because of very peculiar situation combined with vascular surgery, for example, EVAR or things like that. And we were able, let's say, to complete the procedure without the help of the anesthesiologist in basically 90% of the patients, with a very few conversion to local sedation and very, very few conversion to general anesthesia, which basically was in the case of serious complications. And then our patients go straight to the cardiology ward with a monitor, so they don't go to the intensive care or the CCU unless they have complication or unless they come from CCU because they are, emergent cases, so cases with admitted acutely with the compensation or things in which, we are doing the procedure in unstable hemodynamic conditions from the beginning.
So, Dr. Kumar, any comment about that?
Thank you, sir. I think the minimalistic approach, what you're following is very well told. We are worried that we could run short of time. We want to see the entire case. I think we'll proceed with the case steps further.
Yes,
yeah.
We are.
Yeah,
no.
Please go ahead.
Okay, so
please go ahead.
We are ready with the valve. We're ready with the valve.
Okay.
While you're putting the valve in, the point you made earlier about putting a pacer, I think the risk of pacer in AR is much higher. We've seen that with the Valve series, where the rates have been around 20%. There's not calcium to restrict expansion. You're overexpanding the valve. So the need for a pacer may be higher.
Okay. So, Sushil, anybody in the panel, is there anything that you would have done differently?
No. I think you discussed the choices of core valve or sapien. I think they're both the valid choices. So I think we would do this the same.
Well, Sushil,
I have the core valve I would do. I would do core valve. But
yeah, I would do too, and I would also put a stent and not only a wire. But that's the only thing that I would probably do a little bit differently.
No, that's a good point, yeah. In general, when we protect, usually I just open the stent, just to not have the challenge of putting the stent in after.
Well, I agree 100%.
Tulio knows we waste money in New York, though, so he knows that. He's been there.
So I agree 100%. So when we are really concerned about the risk of coronary occlusion, we already put the stent. So no question about that. In this case, our opinion that it's going to be probably okay. So in our opinion, but we may be wrong because there is always some unpredictability in these cases, chances that we are going to finish with coronary occlusion is low. This is the reason why we didn't put a stent. But and also if we have some issue, I don't think we will have a total complete coronary occlusion that we cannot cross the valve anymore. But of course, this is something that we will see.
Tulio, can I ask one other question? One thing that we would do differently, as I think about it, is patients like AR that are higher risk, we will have perfusion or cardio, just ECMO in the room. Because the risk of valve embolization and other factors, or not for the coronary occlusion risk in this case, since I don't think it's that high, but for a pure AR case where we're worried about those type of events, we generally have perfusion. Do you have perfusion nearby? What is your strategy if there's something?
Well, so of course, all the heart team is aware of this case. So we talk with our surgeon, but remember, this is 87 years old patient with several comorbidities. They told us that chances, whatever happens, that they are going to open the chest are very, very low, depending on what is going to happen. But we are ready to switch for that. So this is not just a cath lab room. So this is an hybrid room, and we work really together with the surgeon. So cath lab rooms and operatory room are in the same floor, and surgeons are very, very close. And we, just in case of real necessity, we are ready to switch to open heart surgery. So it's just the logistic that is very favorable, because on the same floor we have operatory room, cath lab room, and we are really, really close together and ready to intervene if it's necessary. But now let's concentrate on the valve. So we are almost ready. So
spingi un po' la guida. Okay.
So fine tuning of the position. So the pigtail was quite deep in the
a little lower, because
yes,
for shortening in AR, deposition lower than with AS.
That's a good point. I mean, when we put when we do an oversizing, so we are aware that the valve is going to shorten more than in volume with regular volume, and therefore we have a tiny bit lower than usual. So how do you like this position? You think we should be a little bit lower? So the valve is moving, but probably with rapid pacing we are going to stabilize it. So how do you like this position?
I think in systole it's a little bit high, which is where it wound up. So I might be a touch lower personally. But
I like the position when the valve goes down. So probably we can also see whether in rapid pacing we are going to stabilize without implanting the valve.
Pacing on.
Okay, so that's what we are doing now.
Pacing on.
Chi c'è il pacemaker? Okay.
Okay, off.
Stabilizing the eye position. I would definitely be a little bit lower. What do you think?
I agree. I would be a little bit lower, because in general, it always ends up where it's consistently with pacing. I would be just a touch lower. Yeah.
Adesso lo facciamo però è un po' in spinta, sì, ma così guarda, adesso è più...
So the position is good when, okay, this is definitely too high, so probably we can do another try like that, holding pressure.
Let's do a try with the angio, ok? Quindi pacing on angio, no implantation at the moment. Okay.
So this is no implantation, okay?
Pacing on, angio. Okay, pacing off. To me, it's okay. I think it's just a little bit high, but I'm not so sure. It's just a little bit. Yeah.
To be honest, I would be lower, so 1 millimeter lower. So what do you think?
I agree.
Okay.
You can adjust a little bit during deployment as well, as you mentioned before.
Yeah, that's true. Absolutely.
Yeah.
But I would be a little bit lower personally as well. Yeah.
Okay, so
la pressione è andata giù bene, vero?
We will probably...
Okay, we are ready. Okay.
Era un po' spinta, Francia, va su,
Okay, so this is the implantation of the valve. Okay, pacing on. Angio.
Okay, now position is good.
Go. Go. Pacing off. Okay, let's...
Okay, there is a little bit of parallaxis, so it's always tricky when you are in a situation like that. But
okay, let's check the coronary first also. It seems very high, the coronary, so, but check.
Yeah.
Pressure is down. Stop.
I think we are safe
okay,
with
so
the coronary.
Let's see if with the pressure is coming up. It's okay. So I think we have some low pressure. Low diastolic.
Yeah,
no.
While you have still the wire, it's probably there is a bias of the wire.
Keep the wire in for a moment, and we did all the way, 2 cc more, right? Okay, so let's remove the pigtail and see. I think we are really safe with the coronary, so we can. But I will keep the protection in case we decide to post-dilate. Yeah.
So did you give the extra volume? Did you give the +2 or no?
Yes, we went all the way, the way. So we put 2 cc more. So now let's get out of the parallaxis and check. The position seems good.
You can see that the valve is a little bit shorter than usual. This is because of the 2 cc more. You see? It looks a little bit... Okay, I think, also now the diastolic pressure is okay. I think we can check.
Okay.
Okay, ci sei? Okay, vai.
Okay, so I think it's a very good result. There is no residual leak. So what do you think?
And I don't think there is need to
Wow.
check I was the coronary. I mean, we are very much okay.
That's remarkable. That looks beautiful. Perfect position, no leak. Very nice.
So, and again, as we were anticipating before, you see that the coronary artery, there's really no issue. And therefore, we are going to, probably it's not even necessary to do ultrasound IVUS because I think we are really safe.
Yeah, no, it's well above, yeah.
I think,
Did the conduction change at all, or is it the same?
The coronary origin looks clearly away from the struts of the valve anyway. I don't think there is any worry of coronary. But nowadays, you follow this regularly in your institute, sir. The AR also you tackle with TAVR now?
So the follow-up of this patient would imply doing a CT scan to see, I mean, how just to document the oversizing, and then she will have just a regular follow-up.
May I have one comment, Sophia and Tulio? I think it's a beautiful result, obviously, as we can see. The thing that I would probably modify when you pace, I would not do the stop pacing. I would just reduce the rate in order to get the ventricle adjusted and not stop and have the risk of a heavy contraction and a removal or a movement of the valve. So that's the only different thing than the thing that I would do a little bit differently.
Okay,
that's an interesting point. People, yeah, we started that as well sometimes. Is turn down the pace to avoid a big extra beat.
Yeah, sure. Do you do that only for aortic insufficiency, or do you use this technique for all the valve?
No. Only in AR.
The aortic insufficiency. Okay.
But I think in this case, I mean, I agree. This is reducing slowly is always something useful. But in this case, I mean, you're not supposed to have a resistance of the valve during systole. So provided the balloon is completely deflated, I don't think, I mean, I totally agree 100%. If we are dealing with self-expanding valve, you have to go very slowly down. But in this case, I think the advantage of that, maybe a very strong systole may still move the valve, but I think that if this happens, it means that your valve is not safely in place, because we have to suppose that if we think that a strong systole, let's say in a normal condition, can move the valve, so then it's, we should be worried. But I agree. I mean, this valve was not designed for that, so everything, every consideration is.
It's just a point of safety that I think may be reasonable. I understand the rationale of doing that, so I think is a good suggestion.
Yes. It's just.
You're right. But I guess as JenaValve gets approved, you'll probably switch the majority of cases to that. But there are anatomic restrictions for Jena where you can't. Even if it's approved, it won't be appropriate in all the cases. So understanding what the roles of this are is still important and what the limits are. So I think
absolutely
this will still have a role. So this is a great demonstration.
I mean, I think exactly. Of course, having in our hands the Jena will solve most of the problems. But for example, I think the cases that Tulio and Antonio showed you before, it was a cases that I think it was out of the present range for Jena valve, because the annulus was 700. So it's something that still, I mean, we have to keep in mind that this is a possibility. It's an extreme possibility for, of course, let's say, a compassionate situation. It will be. Nowadays, it's not like that because we still don't have the Jena, so it's compassionate again, but let's say it's our routine for aortic regurgitation. There are
yeah, this is an important point. So we have to emphasize that these patients are very, very sick, so they are not stable patients, and there is no other option. So of course, we are really selective. We are really strict about the indication because again, it's an off-label procedure, and it's not that we can extend beyond this very strict criteria. Of course, it will be another issue when we will get, and we hope we will have soon, the Jena valve. We will be more liberal in treating aortic insufficiency with the proper device.
Dr. Tulio, you require no valve, it looks. With Edwards only, you did the procedure so well. I think what are the scenarios in which you need to have some amount of calcium definitely to do this, you feel, or even without that you are comfortable doing even for AR?
Thank you, Dr. Kumar. So that's really great point, great question. And you see that in this case, there was no calcium at all. There was no calcium in the annulus, there was no calcium in the leaflet, and also in the other extreme case, the annulus had no calcium at all, even though there were tiny bits of calcium, tiny spot of calcium in the leaflet. So again, the oversizing is very important. And we think that it may be reasonable under the restriction of indication that we already told you, doing this procedure to offer a chance to patients to live longer and stay better. But again, this is really a great case, a nice case for explaining you that even though you have no calcium at all, with the proper oversizing, you may have margin of safety and effectiveness.
Great demonstration.
Of course, there was a point raised before. In terms of safety, is not only, of course, the stability of the valve. We have to consider that when we do an oversizing of the valve, we risk annular rupture. Of course, I think this is, without calcification, it's not a big risk, but we keep this into consideration, take this into consideration, and this is the reason why I agree with the previous comment. I mean, in these cases, you have to prepare all the stuff for the worst. So being ready with ECMO, if this is your approach, or anyway with your surgical team, decide what is your rescue strategy, you need to have it up front. We did our first 5 or 6 cases like that, all in general anesthesia with full surgical backup, so with the surgical staff in the room, the patient ready, prepared for sternotomy just in case. So then we smoothly moved to this less, let's say, invasive approach from the beginning, but mainly, of course, to patients like our patient of today, 87. Of course, if this was a patient 60 years old, probably we would still keep, let's say, a full ready for surgery approach. But anyway, we're still ready for surgery, but let's say it's...
Can I ask one quick question? How many of these have you done, and have you had any embolizations or or any other issues that are that arose in your series?
Not really. So of course, so we have not done big numbers. So I mean, to draw conclusion about procedural risk would be not serious on our side. But we have done some cases of around pure aortic insufficiency. The number, do you remember, Francesco, how many?
It's around 10.
In the range of 10. But these 10 cases went really very well. No issue, no complication. Always implementing the kind of approach that you have seen in this case. No embolization, all the patients are alive, but 10 cases, you cannot make rocket science with 10 cases. And again, I want to remark this concept. They were all 10 cases which were in desperate clinical condition, who have no other possibilities.
And Tulio, I want to point out that we are talking about 10, 11 cases without absolutely no calcium. Because if we take into account patients with minimal calcification, I mean, we are not talking about those patients which were pure aortic regurgitation. but with some spot decalcification. If we take this into consideration, we are above 30, 35 patients.
Yes.
Okay, so I say 10, 11, I'm talking about completely
so cases like that, so
without
pure
calcium.
aortic regurgitation, no calcium at all. So regarding the risk of annular rupture, so a question for you. So is it really even with this kind of oversizing an issue if you have no calcium? So are you aware of cases of annulus rupture in non-calcific valve just because oversizing? So I'm not aware. Do you?
I have not. I'm not aware of any. I've seen second valves or seen valve embolizations as the main issue in these scenarios. But your point of learning how much oversizing, looking at the annulus positioning, people have described the technique of sort of inflating, deflating, advancing the balloon while still pacing and posting more aggressively, trying to create a waist in the ventricle. I mean, I think there are a lot of different things, but I have not heard of annular rupture being the issue in these scenarios, but I don't know if others have.
I think all the audience sitting here are pleasantly surprised, very happy to know how you performed this case, and congratulations from all our behalf for showing this case, almost like a regular aortic stenosis TAVR you did for the aortic regurgitation. Probably preparation, stabilization of the patient, and following all the steps to avoid problems is important. If there are any final comments before we break, sir? Hello?
Yes.
Tulio, thank you again. I don't know if you have any final comments, but this was a great demonstration, beautifully done, great result, and sort of well thought out. So I really appreciate you and your team demonstrating this for us, and it's great to see you, even if it's only on camera.
Thank you all.
So thank you very much.
Clapping from all of us to you.
Thank you very much, Dr. Kumar. It was really a pleasure to be with you. And so let's hope to see you soon. Bye-bye.
Thank you, sir.